All right, well, thanks for joining us here. We're here to talk about enterprise in healthcare. I introduced myself a bit earlier. I'm Rick Kimball. I was a former partner of Goldman Sachs running healthcare investment banking. I'd say when it comes to this topic of enterprise in healthcare, I feel like I've got a bit of an axe to grind. I started doing healthcare investment banking in 1995, so been working on healthcare for some 23 years. And I looked at the data this morning before coming over here. In 1995 in the United States, our per capita spend on healthcare was $10,000. Take that back, $3,700, and it's now $10,000. We were spending 10% of GDP on healthcare. It's now 18% of GDP. And so I feel like over those 23 years, we have not improved the value of healthcare, and enterprise has not done the things that I think we would have hoped to improve our healthcare system. So let's talk about how we make sure that that gets fixed. So let me introduce my august panel here. On my left here is Leah Houston. Leah is a doctor, an emergency room physician who's really focused on the patient-doctor relationship and has been involved in the public policy issues around healthcare as well. Leah has a company, her HPEC, is that how you pronounce it? A Dow for doctors, and we'll hear more from Leah in a moment. We then have Matt Gearhart, Innovation Officer from IBM. Matt focuses on digital transformation and really working on building new routes to markets, new business models, digital asset development, and using data to drive new business models. To Matt's left is Jules Hilliard. Jules is the CEO of Secure Block Technologies, which again we'll hear more from Jules in a moment, but Secure Block is working, building a interoperability platform for enterprise, building blockchain solutions. And then we have Adi Siegel on the end here. Adi is the co-founder and CEO of See-Through Healthcare, a blockchain-enabled healthcare pricing transparency solution, and I'm eager to hear more about that as well. So thank you all for joining us. So to jump into things here, let's sort of start at the high level here. I'd love to hear from, why don't we maybe start with Matt on how is enterprise looking at blockchain distributed ledger technology? And this is really enterprise in healthcare. What do they know about it? How are they approaching the situation?
So we did a survey at the end of 2017 of about 2,000 different healthcare organizations. So that would be everything from hospitals to pharmaceuticals and different kind of entities around that industry. And of those 2,000, I think it was like 2,100 actually, about 17% were actively doing something with blockchain. Now I want to break that down a little bit because there's some caveats to 17%. A lot of those were doing more blockchain projects that would remind you more of a manufacturer supply chain model of blockchain, where they were trying to ensure efficiencies that were happening on cost reduction. So it wasn't necessarily specific to the healthcare industry other than maybe some of the regulations or compliance requests. That said, of the CEOs and the various kind of leaders of the companies that we interviewed, they were most excited about the clinical trial impacts that blockchain could bring to their business. And so as I talked to different leaders in the healthcare industry from an IBM perspective, a lot of them, the way I've been kind of breaking it down is that they understand blockchain from a cost-saving point of view, and they get that. I think that that's an easy case to kind of be made, that they see the other examples that other industries have kind of led the way on. They're starting to kind of understand the way that blockchain can be a less private entity and kind of a shared model, and they see how that specifically could impact their clinical trials, both in accuracy of information, but also kind of improvement of reducing the cost of clinical trials, but also improving their products inside the clinical trials. What I don't feel that they really kind of grasp yet is the disruption of the patient ownership aspect of what blockchain can kind of bring to patients owning their data, to being able to have more bespoke request of the various enterprises. That's something that hasn't really landed yet. So that's the way I've kind of been explaining blockchain at these kind of 3 levels of depth to various kind of entities. And I think that it's a stepping stone. I think it's a journey that most enterprises will kind of be on to kind of get there. But I really kind of fear, and I'm curious to hear a lot from the panel members, how the 3rd level of depth that I described will actually come at them rather than something that they actually kind of trigger.
Mm-hmm. And is it fair to say that I often think when I look at blockchain in healthcare that there's really 2 big buckets. There's drug discovery and the whole pharma world, and then there's healthcare delivery. And I think what I heard you just say was that there's an understanding of what blockchain can do to supply chain, which presumably is more drug discovery than on the delivery side of things, although of course there's supply chain there too. But is it fair to say that it's more the pharma drug discovery side that is starting to see the value of this versus healthcare delivery, or is it not different?
I might be a bit anecdotal in my answer, but I feel like yes. Some of the pharma companies that I have more anecdotal relationships with, or more kind of rather than just kind of the survey that I referenced earlier, they are more used to R&D. They're more used to kind of innovation labs, VC arms, et cetera. So they have a little bit more of a vocabulary to speak about that. But that, again, that might be an anecdotal of my experience. Mm-hmm. I don't know if I'm going to answer that as accurately as some of the other panel members.
Okay, great. Thank you, Matt. So Jules, let's jump over to you. And so maybe you can tell the audience a little bit about your business, and then to build off of what Matt just said, it'd be great to hear what you're learning from enterprise as you talk to them in healthcare, and who seems to get it and be constructive, and who's lagging.
Absolutely, thank you. And we are an IBM partner, so a lot of what Matt just said, I'd like to say ditto. Obviously, we feel the same way. We're a group of enterprise, IT, and cybersecurity professionals that saw the need for blockchain about a couple years ago, saw it playing a pivotal role in changing the landscape of enterprise environments. Because we are very cybersecurity centric, we did take a look at it, at how it can augment current security rules and improve exactly how we do secure our data. I think most of you are aware we are losing the security battle at the perimeter. We're going to spend a ridiculous amount of money this year, about $100 billion on cybersecurity, and I think we're going to lose $750 billion. And it's getting worse. So, the definition of insanity is doing the same thing over and over again and expecting a different result. And that's where we see the inherent benefits of blockchain playing a pivotal role in changing that risk-reward formula for those hackers, make it more risky and make the reward a lot less. That being said, as it pertains to healthcare, healthcare is a very complicated ecosystem. We've had a lot of great talks today on the patient experience and whether or not the executive teams of hospitals understand the value of blockchain. I think everyone sees the value of blockchain, but building the path to blockchain is very difficult. I was going to talk a little bit about supply chain management and the effective role that it's playing. If any of you have any friends in medical device sales or pharma, you have probably seen the sheer insanity on a day-to-day basis of trying to provide the necessary drugs and equipment needed for the operations. It's an extreme amount of cost for that to happen. What we do have to do, though, is figure out a way to build the bridge. How do we motivate and encourage the decision makers to bring in a new technology and moving away possibly from terms like, disrupt the industry or change the industry, and maybe move into more of a augment the way you're currently doing business, make it more effective, lower your cost of doing business, more secure, and improved patient and doctor experience throughout the process.
Well, I think that's a really good point, Jules, and you and I talked about this a little bit. And as I started off this panel, I feel so frustrated that the incumbents just continue to secure their position in the industry. I believe they've got the innovator's dilemma. I don't think they're going to be able to disrupt themselves. I think this is the technology that can be wildly disruptive for healthcare and elsewhere. So I'm super eager to take this on and disrupt these guys. But I think you bring up the right point, which is, as a startup, you're going to ultimately have to play ball with these big guys. And so, I'd be interested in any ideas you have as to how a disruptive company has its cake and eat it too. How do you disrupt? How do you, and at the same time, get to market and maybe leverage some of the distribution capability the big guys have?
Absolutely. And we're all coming at blockchain from a different angle. And we've got this great innovation, and we need that innovation. We need that disruption, the creative thinking. But then we also have these big organizations saying, okay, I have a very monolithic look at how I can get into blockchain. So I think making it interoperable is going to be key. Giving organizations the opportunity to put their toe in the water rather than jump all in. Test applications, make sure that they are working properly, effectively, put them into production, rather than putting in the whole kit and caboodle, put in one finger at a time. And I think slowly but surely, we are going to see the larger organizations continue to push into blockchain.
Great. Adi, why don't you explain to us a little bit about what you're doing at See-Through, and then I'd love to, again, sort of mine your learnings about engaging with enterprise.
Sure. So See-Through is a platform for price transparency. And in fact, what a lot of you are discussing and what you want to see in healthcare is something that we are doing. It takes a while to bring it to the patient consumer. And today we do. I've been at healthcare conferences where they say, well, we can't see the patient as a consumer, but patients are consumers today, and we should treat them like consumers, ourselves like consumers, because that's the experience we have in every other industry. So on the See-Through platform, you can search for providers based on price, location, and quality. The quality metric is a proprietary metric using some of what Alex was talking about before, both price and quality, which gets you to value, and then, of course, what you're willing to give up. And that's an ongoing discussion. We work with government agencies as well. And in fact, next week we have a meeting at the White House to see how potentially they could use this on the national level, work on the state level, and of course with health systems individually too. It's a hard question though. How are they going to integrate it? So one of the things, kind of like what Jules was saying, is we have this infrastructure set up. And most of us, is Aman still in the room? No. We can't just buy a hospital or start a hospital, certainly not in America. In fact, I got to text Aman after this and say, can we try some of your software over there in India? Because it is a great way to test your platform, but there's a lot of restrictions here. And the agencies have set up a lot of barriers. So if you can work with the Epics and the Cerners of the world, then it makes your life a lot easier. And I don't think we're just going to throw up a new hospital that's totally based on, even if it's a permission blockchain, on blockchain. So how are we interoperable? That's the word that's thrown around in healthcare all the time. Blockchain actually makes it a lot easier, obviously. And legally right now, with a lot of, the High-Tech Act, these APIs have to be exposed. It's about actually getting into them. So one of the functions of our platform allows you to go in to, really because of the partner we're working with too, to go into any of the existing EMRs, pull out the data. It's a lot harder to write into health system data, but at least pull it out, and you can create your own interoperable, transportable health record. It looks like an aggregate on your phone, but really all we're doing on the blockchain side is hashing where that data lives, and then it's actually just pulling it every time. So it's still a live record. It still belongs to you, or does it? That's a whole other question. But it doesn't live with us. And that keeps us safe from all HIPAA laws. It keeps us safe just from breaches in general. So it's looking at those creative ways. And over time, then we can really disrupt. But no one today wants to look at, little Lottie walking into a room at, say, Northwell in New York, and I'm going to tell them how to change the system they've taken, decades to build and hundreds of millions of dollars.
But are you suggesting, Adi, that you do feel you need to go in with some value proposition to solve their problem, that they've got issues with their data, to the extent you can help solve that?
Yeah, and so we started the conversation with enterprise on the tech side, but health systems today are also enterprises, right? So I mentioned Northwell by name, and the reason I do that is because they're the largest employer in New York State. That's a big deal. So how do you infiltrate that? Well, you have to figure out what their pain points are, and they're not too quick to tell you what their pain points are. So we have to figure that out too. We know they're not getting paid as quickly as they want to, so price transparency, while they might see it in the first place as something that will start to destroy their bottom line, it actually helps them because we can start to chip away at the 15% of revenue that they're spending to collect the rest of revenue if you start creating these peer-to-peer payments. So there's a lot to be done there. You do need to go in, and they're probably not going to listen to you on your first conversation.
All right, Leah, let's go over to you. So why don't you explain to us what your business is, and then tell us the perspective from the physician role.
Hi, everyone. So I'm working on a solution for the physicians. A lot of people are trying to work on the user's experience for the patients, trying to make your records transportable, owned by you, which legally they are owned by you, but unfortunately they're trapped in these data silos. What people don't realize is that the physician community and the talent of the physician community is trapped in data silos too, silos like Northwell Health. As he said, it's the largest employer in New York State, so they're employing physicians, and that physician talent is trapped there. And people don't realize when you take on a contract and you become an employee of a place like Northwell or any other large health system, you kind of have to sign away your rights, your employment rights, your ability to move. So if your physician leaves a health system, you may not be able to follow them. Or if you leave your employed position, you may get a new insurance in your new employment spot, and you might now need to see a different provider. And so I'm trying to create an experience where patients can stay with their physicians, physicians can stay with their patients, where your records go with you, and your doctor can also go with you. And so I'm doing that by providing a digital identity to physicians, allowing them to move freely in an open healthcare marketplace.
So how does that work, Leah? If you move, your doctor presumably is contracted with a given hospital and plan. So if you move, they economically may not be able to move with you, or contractually, right?
Meaning they will no longer be
reimbursed.
Right, and so that's the whole situation I'm trying to fix. Is if we create an experience where physicians are all on one decentralized database, where we come up with agreements on how we are going to interact with managed care, then if these insurance companies or systems want to work with us, want to have patients come see us, then they can follow our guidelines. Mm-hmm. And so the reason that people use insurance now is because they presume that they can get something for it. So if, people don't realize, but right now there's kind of a mass exodus of the physician community out of the health system. And there's a lot of physicians leaving. There's the direct patient or the direct primary care movement, where physicians are no longer taking insurance, where they're taking monthly fees, they're opting out of Medicare and Medicaid, and it's not because they don't want to take care of patients, but they've found a way to do it much cheaper, and where their relationship with their patients is no longer disrupted. So I'm creating a digital space where all physicians can do that. Right now it's really only primary care that's able to do that, because it's easier to open up your own office and leave the health system and the insurance industry. But what if you're a cardiothoracic surgeon? What if you are an intensivist? You really do your job in a hospital or in a health system. So I'm creating that in a digital space for those individuals as well.
And so what's your strategy to work with enterprise, whether that be the big hospital systems or the insurers? How are you going about that?
So we're focusing primarily on credentialing to start with. It's one big pain point for both health systems and the individual physician community. So right now it's a $5 billion industry. It takes 2, 3, sometimes 4 months to credential for a new hospital or a new health system as a physician. And it costs them somewhere between $7,000 and $11,000. And they're paying, the administrators in their hospitals, the human resource department, that money, and that's not even considering the possibility of redundancies, waste, mistakes in that system. And then it takes 2, 3, sometimes 4 months to bring that physician on. Well, imagine if you could find physician talent and, get it done in seconds. If, there was an opening or a vacancy and you wanted to hire a physician for next week, if you could hire them immediately by going to this database, seeing that their credentials are validated and authenticated on the ledger, you could hire them immediately and come up with a smart contract agreement between you and that physician. So it's kind of a win-win for both sides.
So it all seems logical. So how is Enterprise responding? Are they going, great, Leah, this is what we want, where do we sign?
Well, we're very early. So I'm working on community building first. So we were in Washington, D.C. with some of my founding partners who are leaders of some physician organizations. So I'm building the community first. And once the community is built, then we'll talk to Enterprise.
Okay. So Matt, tell us a little bit more about the perspective of Enterprise as it relates to innovation. And I think one of the key issues here is really, will these enterprises be able to take this technology and dramatically evolve themselves? I've heard from Jules that disruption is a dirty word with these guys. Are they going to try to use this technology to further entrench themselves? Do they want to transform and change? Do you see differences across industries between healthcare and other industries?
The thing that made me make a face whenever you said that was, do they want to entrench themselves? And my first thought was probably. I think that's a natural kind of reaction I think that we've seen from enterprises. You'll have some outliers who will see an opportunity to kind of own a disruption, if you want to kind of simplify the term. From an innovation perspective, my day job, I don't work specifically in healthcare. I work across industries. I do work inside of healthcare from time to time. And healthcare is just like every other industry in the sense that innovation is mostly a business model and a ways of working problem. There are lots of system solutions that can be implemented in a variety of problems that are pretty easy to solve from like an engineering or like a system point of view. It's the business logic and the business rules and understanding the benefit realization that is the real kind of challenge that we've seen. So typically we have the most success whenever there is a very clear problem that has been identified, and then we're allowed to kind of use that as a solution opportunity to leapfrog into a disruptive space, or and that kind of causes some kind of reaction that looks like a disruption. That happens a lot in emerging markets where we have a lot of bleeding problems that just are very urgent to solve, or we have a lot of like ground level opportunities where there's not a really established, ruts in the road problem. The challenge with healthcare is that in addition to every other industry that exists that has that problem that I just described of kind of the innovator's dilemma, or just kind of like a problem of ways of working, is that healthcare is, especially in the US, is infiltrated with an enormous amount of lobbying. And the lobbying kind of effort takes on its own kind of life to kind of hold back innovation at the enterprise level. And I think that's kind of unique to the healthcare industry, as opposed to, let's take another industry that's very controversial, like industrial and building. I've worked with a company recently doing some blockchain and some other kind of innovative tools in there, and they struggled from a ways of working point of view because they had a lot of legacy, they had a lot of things that they just knew how to do, and trying to just get the employees, just the transactional employees, to kind of adopt a new way of being able to manage inventory, which is not a really complicated business shift, was a challenge. And that's the challenge of having a big thing, is you can make big changes, but also it takes a while to change. It's normal. But the challenges with healthcare are unique to the effort of lobbying that I would just flag with this particular space.
And I think you made a point there, Matt, that ultimately you need to sort of find that hook, if you will, that pain point that you can solve for enterprise to cause them to be more open. So a question really for anybody here, what do you think in healthcare are the sort of opportunities where enterprise might be more responsive or more reactive? Well, where are the windows for entrepreneurs to run through? Leah?
Well, I think it's really interesting because Adi mentioned that the health systems don't really want you to know what their pain points are. Or was that you, Jules? I don't remember which one.
Oh, I said that, yeah.
Yeah, so
They're doing just fine.
It's interesting because when you look at the pain points, you point them out, you realize how much money that they're going to need to put into fixing those pain points. So you talk about value, and in order to get value, you need to provide value. So I think the interoperability thing is something that enterprise would like to solve as long as it's not going to hurt them. Yeah. And the same thing with the securities issue. And like they're in this race to try to keep our data secure and to follow the HIPAA privacy rules and things like that. So if you solve that with a solution and they are able to extract value from that while also giving up whatever they need to give up, then perhaps we'll make some changes. I don't know.
Yeah, I would say also. Well, we have someone from Enterprise sitting on the panel right now, but I would say places where they can't reach, right? So should we invent a new EMR? Probably not. No hospital system is going to buy that. But what are things kind of on the periphery of that actually enhance their current software or whatever they're giving to enterprise or whatever they're giving to a health system that makes their offerings better? Right, so in our case, it's price transparency. A tech company doesn't necessarily want to be negotiating new prices, right? Also, insurance companies, also enterprise in some level, are not in a legislative or legal position to negotiate random cash prices. They're bound by laws and also their own contracts where they've put an MFN in for their own prices. So where can we enhance their offerings, I think, is a big thing, and basically run a faster lap than they can, right? They might be pacing us, but I think in certain ways we can outpace them.
One short-term space that I'm really interested in, and I kind of mentioned this somewhat before, are actually two kind of spaces that I'm really pushing with a lot of the customers we have, is the area of procedure and medical trials, because I feel like that has the ability to touch the physician and the patient experience, and that kind of can start integrating outside data, like IoT data, from the little health trackers and et cetera. I think that kind of gives a tough dipping your toe in the water of what a new model could kind of start to look like. So I'm kind of pushing that direction a lot whenever I have the conversations I have. The second is on payment collection, because I think that lack of transparency is a bleeding pain point for both the patient, for the practitioner, as you brought up, and also for the insurer and the payment collector. And I feel that is an area that's just ripe for disruption, to use this word, because everyone sees a problem with it. Everyone I talk to sees a problem with it. And so those two areas are the places that I'm pushing in the short term.
On the payments issue, so I was a chief strategy officer for a revenue cycle management company focused on hospitals. And we found that on the revenue cycle side, basically related to billing, we were talking to the patient 14 times for a hospital procedure. We, the billing people, were talking to the patient more often than the doctor was. And so as you think about transforming programs, we were thinking we've got to get our call centers to actually start to get into motivational interviewing and start to actually understand the care side, because they're touching the patient more than the clinicians are. Why don't we stop there and see if we've got some questions from the audience?
Can't see anything.
Anybody?
Can you see any hands?
All right. Oh, yep, right here.
Question I guess to Matt, when you look at different industries, do you see that culturally they approach innovation in a different way? And specifically in healthcare, how much of that is driven by risk adversity?
Can you repeat the question, Matt?
Yes, in different industries, do they approach innovation in a different way from a culture point of view, a culture of innovation? Yes, and I think that that has a lot to do with the culture of legislation and lobbying is going to make the biggest changes. That seems to be more unique in the healthcare space than other industries that, I mean, even financial services. Like that also is a very regulated, driven by a lot of, I mean, you can speak to this more so than I can, but the laws that happen to exist in the financial services industry are going to make a massive impact on the way that you run your business. But yet the way innovation is approached as a culture inside the enterprise, whenever I have conversations with various healthcare industry players, that is always the kind of stopping point where they say, but da 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 da. For other industries, it's always like, well, but we can't do that because of a legacy. We can't do that because of we're unsure of the results. And that's an acceptable answer that we can kind of work out, and I can break through with them. But the healthcare, they always go back to, but we have a regulation, but we have, that's not the lobbyist strategy. But and I don't get that answer in other industries.
I was having a conversation with, I don't know if she still is in the role, Sister Carol Keenan, who was the president of the Catholic Hospital Association, all the Catholic hospitals. And I was explaining to her the importance of price transparency and that we really wanted to take a leadership role in getting transparency out there. And she stood up across the conference table and leaned over at me and started pointing at me and said, we, the hospitals, have entered into non-disclosure agreements with the payers. We can't talk about price transparency. And I was like, last I checked, you were a nun, and I thought you were in here for the little guy. And she was absolutely speaking the book of the big market share of the big, even nonprofit hospital system, but that was more important to her than price transparency for the patients.
So I'll just add something on that, and we get that all the time because that's the business we're in. And hospital systems and providers are just very confused about the contracts they've signed. What she said to you is just not true. They can't talk about the price they've signed with that payer. And they can't offer a different price to a member of that organization. Doesn't mean they can't offer the price to someone else. And quite frankly, one of our little tricks that we use is HIPAA to our advantage. And you can enter into a private relationship with any patient-provider relationship, and then you can create whatever prices you want. So one of the big things that we have to do in healthcare, technology, and disruption and all of that is simply re-educating the people we are approaching as leaders in the field.
Great. Well, we'll wrap it up there. Thank you very much to my panelists, and thank you all for joining us today.